We are the evidence, the story of consumer research. We are the evidence that people can recover and live meaningful lives. And we are the evidence that it is consumer researchers who bring an understanding of how powerful our lived experience is. Research ought to and can enhance consumer choice, power, and knowledge. This statement is from the Consumer Survivor Mental Health Research and Policy Work Group, who from the early 60s looked to the civil rights movement to develop the philosophy of consumer research. From Brown versus Topeka Board of Education, where it was a black sociologist who said that separate is not equal, and it was his research that became the basis of the civil rights movement and in the school system. Also, women in the feminist revolution used research as a way to get the feminine concept of science into the mental health field, emphasizing collaboration as the way to conduct research, and also creating opportunities for women to conduct research. ACT UP was a group of gay people in San Francisco who formed a group to fight against the AIDS trials when they found that people were dying who weren't given the medication or who were being given a placebo. Research has become a way for people to have voice and to be able to change the society in which they live. But also, research, mental health consumers involved in research can enhance consumer choice, power, and knowledge. I began our story of consumer research when I became involved in consumer research. I saw an ad in the newspaper asking for someone to conduct survey research, and at the bottom it said someone with a psychiatric condition was encouraged to apply. And I found myself at that time involved with the California network of mental health clients who were going to be able to start studying what promotes or deters the well-being of persons with severe and persistent psychiatric problems in California. That was the first consumer research project that was ever conducted, and conducted by mental health consumers. Prior to that, the Hill House project in Cleveland, Ohio, involved consumers in the design of research instruments and data collection, and that was 1979. And the professionals who directed the research demonstrated that Hill House members had the expertise to identify and classify their feelings. Prager and Tanaka, who were the professionals that headed up that research, reported to the Ohio Department of Mental Health on the results of involving mental health consumers in evaluation. And they concluded, representing the consumer's perspective on the meaning of mental illness and the correlates of getting better, the process of client involvement in evaluation, design, and implementation is not only realistic and feasible, it is, we feel, a professional necessity whose time is overdue. The inclusion of consumers in the conduct of research challenged expert-driven research. That research that was conducted by professional scientists and psychiatrists and psychologists. Participation of consumers in defining and measuring psychiatric services precipitated a kind of turf war over controlling human beings in a landscape that included an entire array of service options and widely divergent goals and the definitions of mental health and quality of life. Before consumer research was initiated, biomedical research was the type of research that was conducted in mental health, and that ignored the meaningful human aspects that encompass the personal and the social needs and all the factors that differentiate people from symptoms, brains, or molecules. It was in a review of the literature that Priscilla Ridgway, a consumer researcher, found that there were wide differences between consumers and professionals on the relative importance of treatment goals, identification of problems, barriers to service, and the needs and preferences for housing and supports. From that understanding of that wide divergence grew the concept of the consumer perspective, the value of consumer lived experience in conducting research. I often have used the example of the blind man and the elephant, where all of these blind men are feeling different parts of the elephant and project what the world is like based on what they are feeling. If consumers aren't part of that dialogue, then it's only partial knowledge. The story of mental health consumer research is a story of bringing new values, new knowledge, new understanding to the field of mental health. Adopting the slogan, "Nothing about us without us," mental health consumers have struggled for over 3 decades to be meaningfully involved in the design and implementation of mental health services research and evaluation. In 1986, the California Network of Mental Health Clients wrote a successful research proposal to the California Department of Mental Health to investigate what factors promote or deter the well-being of people with severe mental illness in California. I became the principal investigator of that study, along with my co-investigator, Ron Schraber. The Wellbeing Project was the first survey research project in history that was developed, administered, and analyzed entirely by people diagnosed with mental illness. We surveyed over 500 mental health consumers, family members, and service providers and collected over 40 hours of recorded testimony. The project contributed to new knowledge. That included the power of personhood in promoting well-being, the importance of the consumer perspective in conducting research and evaluation, and also the concept of negative outcomes produced from coercion in the traditional mental health service system. That was all new knowledge from this study. But most important, the well-being project was about people coming to voice. And that was the critical lesson for the consumer researchers that were to follow. To support their advocacy efforts, consumers have initiated their own studies in the following years. They identified the needs and preferences for housing and supports. They profiled state mental health systems. They developed new measurement tools like Judy Chamberlain's empowerment tool or Ruth Ralph's recovery assessment. They introduced consumer satisfaction teams, and they promoted the use of consumers in focus groups as a way to collect meaningful input of consumers up front in the research. Consumers as researchers began to apply sophisticated data and health informatics strategies to public policy debates, peer-run services, and the conduct of science itself. For example, in a series of focus group sessions that were funded by the Center for Mental Health Services, which is part of SAMHSA in the federal government, in 1993, the Consumer Survivor Mental Health Research and Policy Work Group, which was that coalition of consumer leaders and researchers, they began a systematic articulation of the outcomes of mental health services and supports that a state mental health system should produce for their service recipients, all from a consumer perspective. From the brainstorming and sorting and ranking sessions that were conducted following the focus groups, maps were generated that identified domains and performance indicators. That was a new technology called concept mapping. According to the focus group participants, traditional mental health services pathologized problems in living. They held low expectations of consumer achievement, were paternalistic, offered a limited range of options, and defined anger as a symptom of mental illness. The most frequently identified concerns were mental health provider threats of involuntary treatments, subtle forms of coercion, lack of respect, and debilitating side effects of psychotropic medications. Recovery, personhood, well-being, and liberty were identified as valued outcomes. Building on these preliminary studies, consumers advocated for a value-based, consumer-oriented mental health statistics improvement program report card, which included some of the performance indicators that they had identified. The most significant one that was not included in that report card had to do with the concept of recovery. One thing that we learned in those early years between 1980 and 1990, that the questions you ask lead to the answers that you get. And it was important that consumers conduct research and ask the questions that were most relevant for them. So questions asked about recovery produce research about recovery. But questions asked about dangerousness produce research about consumers being dangerous. It was really important that consumers not only were the ones involved in the focus groups or learned to do surveying in the field, but that they took control or worked as a partner with traditional mental health researchers in designing research, and particularly designing the tools to measure those things that consumers found to be important in their recovery. In 1995 through the year 2000, for example, a outcomes protocol was developed and field tested and disseminated that was entirely designed by mental health consumers, funded by the University of Illinois at Chicago's National Research and Training Center. It helped consumer-operated service programs and other community-based peer programs begin to look at the issue of outcomes and their own service provision. In 2002, there was a national research project for the development of performance indicators of recovery for mental health systems. And that evolved out of the collaborative efforts among a team of consumers and professionals, researchers, state mental health authorities, and a consortium of sponsors to look at what helps and what hinders mental health recovery. They use structured focus groups in 9 states with a diverse cross-section of 115 consumers to gain knowledge about what helps and what hinders mental health recovery. Performance measures were developed and incorporated into a systems-level recovery protocol, and that is rapidly becoming a standard in the field by states to assess how well they're progressing in becoming a recovery-based mental health system. Also, Jean Dumont and Chris Jones, both mental health consumer researchers, discovered that access to a crisis hostel program produced healing and recovery and a greater sense of empowerment than traditional hospital-based services. And then the COSP Multisite Research Initiative, 1998 to 2008, was the largest and most rigorous study of consumer-operated services ever conducted. It was what they call a randomized controlled trial with 8 study sites, a coordinating center, and 1,827 participants. I was the principal investigator of the coordinating center in that project. Our research found that peer-run services were effective as an adjunct to traditional mental health services, improving the outcomes of adults diagnosed with serious mental illness. And also, we established a significant link between the service elements of peer-run programs and the positive psychological functioning of participants. We identified 46 common ingredients of consumer-operated service programs, peer structures, values, and practices that promote well-being, empowerment, and the hope of recovery among participating adults diagnosed with severe mental illness or impairment. And that the results of that study establish peer-run programs as evidence-based practices. The COSP study was also the most participatory of studies involving significant numbers of consumers at all levels of the project in meaningful research roles. And it represented a major advance in bringing the voice of persons with mental illness into dialogue with researchers to deepen the understanding of the programs and the services that consumers had developed for themselves to promote recovery. However, The empowerment of mental health consumers through the administration, design, implementation, and analysis activities created tensions between consumer researchers and professionals in the COSP study regarding issues of authority, expertise, and language. On the other hand, the growth and acceptance of such partnerships shows the potential for progress when consumers and professionals work together in relationships of mutuality and respect. In order to accommodate diverse perspectives now part of the research environment, it is necessary to pause and encourage critical discourse and to incubate new relationship and ideas as participatory processes are established. We have to collaborate, work together, and learn to listen as well as share our perspectives. Ultimately, consumer participation in research tests the proposition that the integration of consumers in research can enhance scientific knowledge that is useful and meaningful for all participant groups. Methods that utilize a participatory style of research have been shown to enrich and validate knowledge. They can improve the accuracy of the description of an organization, the service delivery system, and a broad range of outcomes. Participatory models have the capacity to examine the context in which evaluation occurs, to go beyond the statistics that record numbers to include the meaningful interactions of those living with a psychiatric diagnosis. And as a result, new questions, methods, and ways of interpreting data have emerged in the margins of traditional services research. I have included here a model of consumer action research, and something that I would argue is found in most consumer research efforts. First of all, research is organized from the bottom up, not from the top down through the priorities of the funding streams like the federal government or charities, but from the bottom up, from the consumers themselves who identify what they need, what they want, what is important. Consumer perspective is sought and respected, and I would also say is absolutely essential. Participants, those that participate in the research as research subjects, are seen as study partners, not as objects to just collect information from. There are issues of ownership and control, and those are confronted, not ignored. The evaluation story is told. Telling one's evaluation story is important. And personal impact is captured. Knowledge exchange is the key goal. The point of departure in consumer action research is the engaged participant, and this is very important to know. The engaged participant. That engagement means that the person is productive, feels productive participating in the research, is conscious of what they're doing and the value of it, is thinking, feeling, being creative, honoring others' values and choices, is coming to voice, and is respectfully listening.